Liver. Always a few questions on liver. Very important organ, your liver. Your liver does a whole bunch of things. Your liver has Kupffer cells, detoxifies the blood. Your liver also has cells that manufacture and make bile. Your liver also synthesizes amino acids, right? It makes amino acids. Your liver also makes albumin, prothrombin, and fibrinogen. Prothrombin and fibrinogen, very important for clotting. That's why you'll notice that people with liver disease don't clot too well. They tend to bleed very easily. Also, your liver makes albumin. So people with liver disease, because they have low albumin levels, they tend to get ascites. All right. You know, the blood from your body all goes to your liver to become detoxified, you know? That the blood drains from your esophagus and goes to your liver. Drains from your stomach, goes to your liver. Drains from your spleen, goes to your liver. Drains from your intestines, goes to your liver. That your liver receives 1,500 cc's of blood per minute. Now, when I read that, I said, this got to be a typo. Because when I say to myself 1,500 cc's of blood, I'm picturing it like an IV bag and a half. That's a lot of stuff going to your liver every minute. But that's what happens. Your liver receives 1,500 cc's of blood per minute to detoxify and work with. So if you have a diseased liver, it's unable to accept all this blood coming in. And since it's unable to accept those blood coming in, you're going to get a backflow. You're going to get a back pressure. You're going to get a back pressure of blood through your esophagus and get esophageal varices. You're going to get a backflow of blood into your stomach and get gastritis. You're going to get a backflow of pressure into your spleen and get splenomegaly. You're going to get a backflow of blood into your intestines and get hemorrhoids. So it doesn't pay to drink. So anyway, your liver is a very important organ. It also converts glucose into glycogen and glycogen back into glucose, right? Your liver does that. And your liver converts ammonia into urea. So your liver will take ammonia and convert it into urea. So you see that your liver is a very important organ. And that if your liver doesn't work, you're unable to detoxify the blood, you don't have any amino acids, your albumin levels are low, you get ascites, your clotting's off the wall, you're unable to convert glucose into glycogen, glycogen into glucose, you become hypoglycemic. And because you're also unable to convert ammonia into urea, you wind up having high ammonia levels. And high ammonia levels will then put you into hepatic encephalopathy. You got to remember that when you have people with liver disease, there are a few things that should never ever happen to them, and this would be one. When you have liver disease, you never want anyone with liver disease ever to get a low potassium level. Because whenever you have a low potassium level, your kidneys are going to hold on to potassium. And when your kidneys hold on to potassium, they always hold on to an ammonium ion. And so then if you're holding on to potassium and then your kidney's holding on to ammonia, it'll put you into a worse state of hepatic encephalopathy. That's why people with liver disease, they always give them aldactone. It's a potassium-sparing diuretic. You know, you cringe when you hear that people with liver disease are going to be on Lasix, because you never want anyone with liver disease ever to have a low potassium level. This arrow went down, so these arrows got to go up. You never want anyone with liver disease to have an increase in their BUN, because having an increase in your BUN, one of the byproducts of BUN is ammonia. So you don't want them to get dehydrated. You don't want them to run a high fever. You don't want anyone with liver disease to get any kind of protein. And that could be protein meaning food or protein meaning blood. You don't want anyone with liver disease, you don't want, but they always do, have a GI bleed. It's like a horrible thing. If you have liver disease with a GI bleed, blood is a protein. And whenever you're taking protein, one of the byproducts of breakdown of protein is ammonia. So it makes their condition worse. You never want to give them steak for breakfast, lunch, and dinner. That's not a good thing either. Unless you live with an alcoholic who's abusive, then you can give them steak 3 times a day. then they gradually go into hepatic encephalopathy, and he'll just sit there flapping his arms, and that's it. Just something to think about. You never want anyone with liver disease to have an increase in acids, and that could be an increase in acids because maybe they have a low blood pressure and they develop a lactic acidosis, or what else? Or acids being, what else? Ringer's lactate. You never want them to get Ringer's lactate, right? That'd be very, very bad. If you have liver disease and I give you Ringer's lactate, you know, whenever I give you Ringer's lactate, the lactate is always converted into bicarb by your liver, by a healthy liver. If I was to give you Ringer's lactate and you have a diseased liver, that diseased liver is unable to convert Ringer's lactate into bicarb. It stays in your body as lactate. But then your kidneys will convert the lactate into acid, into lactic acid, and then, because I've now increased your acid, you go into hepatic encephalopathy. So that whenever you have things that increase your ammonia level, such as these things, all these things increase your ammonia level, it causes you to go into hepatic encephalopathy. I'm taking care of a post-op patient. He had liver surgery, and so he'd had that done on Tuesday. Saturday night I come in, I'm taking care of him. The nurse is busy, but the surgeon was looking at the chart. So I went up to him, I said, listen, I'm going to be taking care of your patient here. I just wanted to know, I didn't get a chance to look at the chart, you know, what's going on? He looks unconscious to me. So he said to me, well, he had surgery on Tuesday. He had some kind of a Levine shunt for liver disease. And because he has liver disease, it takes a long time for the anesthesia to be broken down. So I said to myself, it takes a long time for the anesthesia to be broken down. What do you mean, he's still under anesthesia? It's a week later. So I said, give me the chart, will you please? So I got the chart. I just opened up one page and I figured out what's happening. So I said to him, I said, you're wrong. I said, just figured out what's going on with the guy. There's a reason. Well, there's two reasons why he's in a coma. Reason number one, you're his surgeon. And reason number two, you've been giving him Ringer's lactate for the last week. Now, whenever you have anyone with liver disease, and you know he has liver disease because you did surgery on him Tuesday for his liver, right? Okay. So whenever you have liver disease and I give you Ringer's lactate, the lactate will not be converted to bicarb. The lactate will be converted into lactic acid by your kidneys. And I learned in nursing school that whenever you give anyone with liver disease any kind of proteins or any kind of acids, they go into hepatic encephalopathy. Your guy is unconscious not because he's still under anesthesia. He's unconscious because you put him into hepatic encephalopathy because you've been ordering Ringer's lactate. So I bet if you did a protein, I bet you if you did an ammonia level, I bet you it's 500. So if we did an ammonia level and came back 480, I'm like, oh, I should have waited like a half hour. Would have been up to 500. Would have had it right on the money. All right, so then I had to give the patient lactulose, lactulose. So that's like a good drug to give, right? Hello. So then the night was very productive. And then the next day I come in, I work 7P to 7A. And when I got there the next day, the patient was awake. He was awake. He wasn't like awake, like I wouldn't put him behind a grill during lunch hour, but, you know, he's pretty alive. And I said to the wife, I said, look, he's doing wonderful. She's like, oh, that doctor so-and-so, he's such a great doctor. I'm like, oh, the Lord works in very mysterious ways, you know? All right. I tell you, I'm working on a book, and I need people to help me write it, and I'm not getting this kind of response I thought I would. I'm putting a book together called Thank God I Went to Work Today. Stories of nurses at the bedside that save human lives on a daily basis. Send me your stuff. We'll split it. I'll get on the Oprah show. We'll get somewhere. I know, I'll publish it. I only got like 30 people responding. I want it to be, the whole thing is I want it to be a book like this, like Shogun or something. You know, like a big book like that. You know, little, but really thick, you know? Okay. And for sure I'll have nurse administration doing everything in their power to remove my RN license. No, because when I went on Nightline, I had people write to me that they were going to do everything in their power to get my RN license revoked. Because what I did was instill in the American public fear about entering into the hospital. Like you shouldn't be nervous, there's a janitor suturing your head wound. Rather than a pat on the back, I get these threats that are going to do everything possible to get my RN license revoked. Please. Should do it now. I'm old enough. You can have it. All right, other things we have to talk about. On the exam, they ask you, what's the complication of neomycin therapy? So stupid me, I get it wrong. Not like teaching CCRN reviews and getting questions wrong. So I think ototoxicity or nephrotoxicity or some kind of toxicity I put, because neomycin, you've learned that, neomycin or any mycin's toxicity. Anyway, then I read, and I learned that neomycin is not absorbed systemically, just stays in your gut. So you can't get ototoxicity, you can't get renal toxicity. So then I also learned that in your gut you have a lot of bacteria. And the bacteria in your bowels make vitamins. The bacteria in your bowel, you make riboflavin, folic acid, you synthesize vitamin K. You do a lot of things, the bacteria in your bowel. So when you are on neomycin therapy, that antibiotic just stays in your bowel, kills all the bacteria. The bacteria, when it makes those vitamins, it releases ammonia. For me and you, no problem, because our liver will convert it into urea. But for people with liver disease, that bacteria making vitamins, releasing ammonia, puts them into hepatic encephalopathy. So that's why you give them neomycin. Neomycin just stays in the gut. It stays in the gut, destroys your bacteria flora. So therefore, you don't make any vitamins. And so one of the complications of neomycin therapy is vitamin deficiency. So I got that wrong on the test. Because I'm working in critical care, and the last thing I'm looking for is a vitamin deficiency. I got people with ARDS, I got people with septic shock, I got people with 10 pumps going on, and I'm intra-aortic balloon pumps, so I'm going to look for a vitamin deficiency. And what does that look like? I get the bull legs or something, or little things over here. I mean, I don't even know what to look for. But anyway, that's the answer on the test. Vitamin deficiency. So back to your bowels now. Besides having bacteria in your bowels, they also ask you, what's the normal bowel sounds? And the normal bowel sounds, I got this wrong, because I didn't know you're supposed to have 5 to 34 rumbles a minute. I'm thinking 34 rumbles a minute. That's a lot of rumbling going on. I'm thinking I'm running for a bedpan if I'm hearing 34 rumbles a minute. That's like every other second your stomach's like talking up. Hey, it's time for Lamodal over here or something, Imodium or something. But anyway, 5 to 34 rumbles per minute. And then you're supposed to listen in each quadrant for 5 minutes in each quadrant. That means I'm spending 20 minutes. I'm hanging out 20 minutes listening to this guy's stomach. 20 minutes. Do you know what I can do in 20 minutes? I can do a lot of nurse work in 20 minutes. Yet they want you to be hanging out over someone's abdomen for 20 minutes counting. 1, 2, 3, you're up like 997, 998. Then your nurse manager hits you with a suction catheter. She said, what the heck are you doing? Hey, don't think I'm not doing anything. I'm doing something. I'm not only counting bowel sounds, I'm making vitamins. I'm making riboflavin, folic acid, and I'm also synthesizing vitamin K. Because you make vitamins. Hello. All right, here. Oh, your patient is jaundiced. Is it hepatic failure or biliary tract disease? That is it liver failure versus gallbladder disease? So on the exam, you need to differentiate who has gallbladder disease as opposed to who has hepatic failure. Nothing like focusing on the synergy model. Here's how I explain this. If you have somebody that's jaundiced, they can either have a problem with the liver or the gallbladder. So how do you know? Well, you got to look at the bilirubin. Here's how I explain it to you. And here's the only way that I learned it. That's why I have to explain it to you this way. Mr. Bilirubin travels with Miss Albumin. All right? Mr. Bilirubin, Miss Albumin. They're dating, right? So here they are. They're holding hands. They're going through your blood, and they're dating. They're unconjugated, right? They're indirect. They're unconjugated and indirect, Mr. Bilirubin and Miss Albumin. Okay, so there they are like this. Then they go to the liver. In the liver, they become conjugated. They become direct. They get married. Now, once bilirubin and albumin are conjugated, they go to the gallbladder to live happily ever after. So, if I have somebody that has jaundice and has very high levels of indirect or unconjugated bilirubin, where's the problem? Liver. If I have somebody that's jaundice and have very high levels of conjugated or direct bilirubin, where's the problem? Gallbladder. They couldn't get in to live. So that if somebody has jaundice, they either have liver disease or they have gallbladder disease. If they have liver disease, you'll have high levels of indirect and unconjugated bilirubin. If they have gallbladder disease, you'll have very high levels of conjugated or direct bilirubin. That make sense? This after lunch, that's a good thing. So again, the issue is unconjugated or indirect bilirubin. All right, goes to the liver. In the liver, it becomes conjugated or direct bilirubin. All right, to get married. And then they go to the gallbladder to live happily ever after. So if I have somebody with increased indirect or unconjugated bilirubin, it's hepatic or liver disease. And if I have somebody with increased direct or conjugated bilirubin, the problem is gallbladder or biliary tract disease. Tell you, it makes you want to go into work, doesn't it? No, not yet, eh? Never mind. Ruptured spleen. This is the abdominal trauma question. Always one question on a ruptured spleen. You need to know that when someone has a ruptured spleen, 55% of people will give you left shoulder pain. Right? They'll give you left shoulder pain. That's known as Kerr's sign. Why don't I have it here? Oh, here it is. Kerr's sign. It's known as Kerr's sign. Left shoulder pain. About 55% of the people have that. You need to know that it always gets, not always, but it gets misdiagnosed a lot. I mean, if someone comes in multiple trauma and they're telling you they have severe pain in their shoulder, then, you know, you think spleen. But if, you know, a lot of people don't give you good history, and so they come in like a day after the event. We had a woman that came in complaining of severe pain. And this is when we used to have the ward clerk on the night shift in the ER doing triage because it was too expensive to have a nurse do it. So they had like a ward clerk do it, okay? And they gave her a little training, and they told her if anyone comes in complaining of jaw pain, because not all heart attacks you have pain over here. So anybody coming complaining of pain over here or down the arm, get the nurse immediately. It means they're having a heart attack. So one was brought in by her husband. She didn't look well. She's pale. She's diaphoretic. She's not looking good. She's complaining of severe pain. So the ward clerk learned this in her, you know, one-day class, whatever, on how to triage ER patients. So she comes running in the ER and she gets the nurses. She's like, "There's a lady out there, chest pain, chest pain." So the nurses run out. "Where's your chest pain?" "Oh, arm, oh." So they bring her into the ER, hook her up on the monitor. She has a right bundle branch block, but not most, but, you know, it's common to women than men. She has a right bundle branch block, no big deal. A lot of people are born with it. And she's tacking away at 150. Well, right bundle branch block at 150 in V1 or MCL1 lead, not lead 2, because lead 2, there's no difference in lead 2 when you have right bundle branch block, right? You'll only see a weird configuration in V1 or the MCL1 leads. But anyway, so when you have her on V1 or MCL1 and she has a right bundle tacking at 150, you're like, oh my God. Then they take a blood pressure like 70 pounds. She's all diaphoretic, so everyone's like, oh God, oh, cardiogenic shock, cardiogenic shock. Then they bring her up to CCU, and I'm the nurse. And I got reported, you know, she's like 38, 39 years old, cardiogenic shock. I'm like, oh my God, what the heck is she doing here? You know, send her to New York, will you please? But anyway, where's the family? Let me talk to the family. All right. So then they bring her up, and then we're swanning her, and I'm like, you know, what kind? First of all, I'm looking at EKG, and the doctor tells me, I said, not for nothing, but I don't see an MI here. So he says, you can't see an MI when they have a right bundle branch block, which is an absolute lie. You can't see an MI when you have a left bundle branch block. When you have a right bundle branch block, you can see an MI. Easy. So then I'm like, oh, please. All right. So then I'm like, okay. All right. But sometimes it doesn't show up, MI. So I'm like, oh, okay. So then she's in cardiogenic shock, right? Cardiogenic shock, no blood pressure, no urinary output, tachypnic, she's looking bad. So then when we're putting the Swan in, everything's like, the right side of the heart, very low pressures on the right side of the heart. And then, and then very low pressures left side of the heart. So then I'm saying to myself, what kind of MI is this? Because if you're having an MI cardiogenic shock, you would expect, first I expect like pulmonary edema and stuff like that, unless of course she's having an inferior wall MI, where you infarct the right ventricle, so then you would have clear lungs, but then the pressure on the right side of the heart would be elevated, and hers was like, 0. So then I'm saying to myself, something's wrong here. So I go out and I speak to the husband, and I'm like, tell me what's going on. Because when I went to change her leads, I saw like a bruise over here. He said to me, the other day she was hanging curtains and she fell off the ladder where the steps are, and she hit the banister, and the banister went under her rib cage. So then I said to myself, bada bing, spleen, splenic rupture, shoulder pain, tachycardic, hypovolemic. I figured it all out. So I went in and I told the doctor, I said, listen, I don't think she's cardiogenic shock. I think she's, hypovolemic shock. He was like, Laura. She in CCU, she got to have cardiogenic shock. It's like you're in CCU, you can only have cardiogenic shock. So then I wasn't getting anywhere with him. So then I figured, let me call up a few of my friends. I called a few surgeon friends of mine. I said, listen, Milton, can you come in here? You got to bring someone down to the OR. Anyway, so he came in, and then the cardiologist left. Goodbye. And then, with the most stupidest orders, all right, goodbye. And then the surgeons came in and blah, 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 blah. Anyway, they wound up bringing her to the OR. When they opened her up, she had a ruptured spleen. They wound up giving her 13 units of bank blood. And she got a little ARDS, but then she wound up living. But then I got in trouble because, I forgot to tell the cardiologist I was calling in the surgeons and stuff. So anyway, another life saved for $15 an hour, and then you get in trouble, Unbelievable. But she got misdiagnosed ever since she stepped foot in the ER, because everyone was like cardiac. And then once you have them CC, it was cardiac. Meanwhile, it was ruptured spleen. It pays to float, pays to float. Here we go. In order to most accurately establish that your patient has no bowel sounds, you must listen to each quadrant for at least 2 to 5 minutes. Good. The usual order for carrying out a physical assessment of the abdomen is... Right. Look, listen, and bang. Right? Look, listen, and feel. So you got inspection, auscultation, percussion, palpation. Palpation is the most important thing. Only you got to save it for last. You haven't? No. You got to save it for last because if you go bang on someone's stomach. Oh, now I ain't got no glasses here. I can't read this. I'm postmenopausal here. I got no eyesight. How about you?
Claudia Tabbitt. Claudia Tabbitt. She's the winner.
Oh, Claudia Talbot is a winner. What do you mean by that?
Okay. They win a prize.
Oh, they won a prize.
Yeah.
Oh, Claudia Talbot won a prize.
And,
C Specialty Professional Services.
And, Lydia Cato.
Lenita Cato won a prize from New York Presbyterian.
Yes. And to see me.
And to see my friend over here, right? Jerome. So any of you ladies there who won, what'd you win? Trip to Bermuda. No, you don't go to Bermuda. Never mind. The hurricane there. Never. Yeah. Oh, wow, that's a good prize. Never mind. So anyway, inspection, auscultation, percussion, palpation. Palpation is the most important one, but you got to save it to last because if you go banging around someone's stomach rather than 34 rumbles a minute, you hear like 100. The function of the liver includes all the following except. Right. You see, the liver does synthesize prothrombin, fibrinogen, and albumin. The liver makes amino acids and albumin. The liver is responsible for making hepatocytes that secrete bile. A is the wrong answer because the liver does not form ammonia to remove urea. It makes urea in order to get rid of Ammonia. Very good, very good, very good. Nursing interventions for the patient with hepatic failure include restrict protein in diet? Yes. Avoid the use of narcotics and sedatives and tranquilizers? Yes. Give lactulose and neomycin as prescribed? Yes. So the answer is all of the above. Good. The underlying cause of most bleeding esophageal varices is, and you would say, portal hypertension. Portal hypertension due to liver disease is the most common cause of esophageal varices. The rationale for use of neomycin in the setting of liver failure is to inhibit the production of ammonia by the intestinal bacteria. Good. The administration of vasopressin should be most carefully monitored in patients who have coronary artery disease, because it's not only a water hormone, but also vasopressin. Urea is formed by the liver to rid the body of ammonia, right, to get rid of ammonia. Good. The inability of the liver to conjugate what substance is a primary contributor to hepatic coma. High levels of what give you hepatic coma? Ammonia. Good. Which of the following may precipitate the onset of hepatic encephalopathy in patients with severe liver dysfunction? So what would cause someone with severe liver dysfunction to go into hepatic encephalopathy? And all the above. So that diuretics, in that it'll make you lose your potassium. A low potassium level causes your kidneys to hold on to ammonia, hepatic encephalopathy. Acute infection raises your BUN. The breakdown of BUN releases ammonia, hepatic encephalopathy. GI bleeding. GI bleeding is a protein blood in your GI tract. The breakdown of that would release ammonia, so the answer is all the above. Which of the following may contribute to the precipitation of hepatic encephalopathy in the patient with liver failure? Again, all the above. Because GI bleeding is blood, protein. Hypokalemia, whenever you have a low potassium level, your kidney holds on to potassium, but also holds on to ammonia. And hypotension would increase the acids in your body. Whenever you're hypotensive, you build up in lactic acid, and giving anyone with liver disease any kind of acids, they go into hepatic encephalopathy. Ecchymosis around the umbilicus, indicative of peritoneal bleeding, is called Cullen's sign. Cullen's sign, good. Chava's-Tech, that's something you see with a low calcium, right? Facial twitching. Gray Turner's, black and blue, flank groin when you have pancreatitis. Trousseau sign, another thing you see with low calcium level. Put a cuff on somebody's arm, pump it up, and you see twitching going on. That's Trousseau with hypocalcemia. So Cullen's sign is a black and blue belly button. Pulmonary complications of acute pancreatitis would include what? Would you get ARDS? Yes. With pancreatitis, would you get elevation of the diaphragm and bilateral basilar rales? Yes. Would you get atelectasis of the left base? Yes. So the answer is all the above. Good. Which of the following analgesics is a drug of choice in managing the pain of acute pancreatitis? And it'd be like a Demerol, and you got to stay away from morphine. A blue, green, brown discoloration in the flank and groin due to retroperitoneal bleeding is Gray Turner's. Good. Cullen's sign is a black and blue belly button. Kernig is meningeal irritation. That's where you take the leg and stretch it out. When you stretch it out, they get pain in the hamstring and in the neck. And Welch's sign is grape juice, right? You drink the grape juice and you get Welch's sign. Kernig's you get with meningeal irritation. When you have meningitis, how do you differentiate bacterial meningitis from viral meningitis? What's the glucose level with bacterial meningitis? Low. Good. Is it good to have doll's eyes? Yes, it means you have brainstem integrity. If I have an on-cal herniation, the first sign I'm going to get is what? Is it a change in the level of consciousness, or am I going to get a change in the pupil? Pupil. On-cal herniation, change in the pupil. Get a change in the pupil on the side of the boo-boo. And where do I get a Babinski? Opposite side. Good. There'll be no living with you. Patient assessment findings indicative of bowel infarction would include all the above. If you have a bowel infarction, you get hyperactive bowel sounds and leukocytosis. You get hyperresonance and abdominal tenderness. And you get an absence of dullness in the liver area. It's more like a tympanic noise you're hearing when you have a bowel infarct. All right, good. Well, we're going to take a little bit of a stretch. Just take a 15-minute stretch. Go put cold water on your face. When you come back, we're going to do hemo and we're going to do renal. Do we have any old nurses here? Anybody in nursing like 45 years or something like that? No, really, where are you? Who's in nursing 45 years? Stand up. Stand up. How many? Ah, you're a baby. You're in nursing 45 years? You can't be. You're too young looking. You've been in nursing how long?
42 years.
How many?
42.
42 years. Anybody else? Anybody else? Who else? Anybody in the 40s? No? Well, 42 years. Get over here. We've got some money. Got $100 for you. Hey! $100. $100. Yeah. Usually I give nursing products, but who the heck wants a nursing product? Nah, $100. Enjoy. Yeah, usually I give nursing products, but you know what? You're in nursing 40-something years. The last thing you want is another nursing product. All right, onward. Here we go. We're going to do renal. Renal is 5%. So you're only going to see 10 little itty-bitty baby questions. That's it. Just 10 little itty-bitty baby questions. I'm going to give you more than enough information to answer all 10 questions correctly. You will not have a problem with renal on the exam. We're going to talk about renal failure, one question on renal trauma, and electrolyte imbalances. Here we go. A little bit about the anatomy. They have like one question on the anatomy. You have a proximal tubule, you have a loop of Henle, and you have the distal convoluted collecting tubule. The proximal tubule reabsorbs everything. You name it, your proximal tubule in your nephron will reabsorb it back into your body. So if your body thinks that, you're low in potassium or chloride or bicarb or whatever, your proximal tubule will reabsorb potassium and chloride and sodium and bicarb and hydrogen and phosphates and you name it, your body will reabsorb it. See you tomorrow. The kitchen sink, whatever you're low in, your body will reabsorb it, and that's your proximal tubule. Now, the loop of Henle is responsible for the concentration and dilution of urine. And then the distal convoluted and collecting tubule, this is where ADH works to make your kidneys hold on to water. Good. Probably the only thing you remember, ADH and water. Just walk out of here, ADH. So this is what you have to know about the anatomy. Proximal tubule reabsorbs all the electrolytes and anything you need. Your proximal tubule will reabsorb it back into your body. Your loop of Henle's are responsible for the concentration, dilution of urine. And the distal convoluted collecting tubule is where ADH works to reabsorb water back into your body. So that's a little bit of the anatomy. Let's say a few words about acute renal failure. When someone has acute renal failure, it means that they have a decrease in urinary output. A decrease in urinary output less than 400 cc's in a 24-hour time. That's what acute renal failure is. You have less than 400 cc's of urine in a 24-hour time. Now, when you have acute renal failure, you can either have pre-renal acute renal failure, or you could be in the renal stage of acute renal failure, or you could be in the post-renal stage of acute renal failure. So when you look at your core curriculum which goes into renal failure. It describes renal failure, acute renal failure, as 400 cc's or less of urine in a 24-hour time. Your core curriculum will say that people can be in the pre-renal state of acute renal failure, the renal state or stage of acute renal failure, or the post-renal stage of acute renal failure. Now, I don't talk about the post-renal stage of acute renal failure, because in my mind, it is not renal failure. You see, when you say that someone's in the post-renal stage of acute renal failure, it means that they made urine is just not coming out. Now, why should your urine not come out? Well, maybe you have prostatic hypertrophy. It's wrong with your prostate gland. And so that, to me, it's really not a kidney problem. It now becomes a urological problem. But they include it in your book. They don't ask you on the test, but they include it in your book, so I don't want you to think I'm leaving it out, and I don't know I'm leaving it out. I'm purposely leaving it out because it's not on the test. And also, in my mind, it is not renal failure. Because to be in the post-renal stage of acute renal failure means that you made urine. Good stuff. It's just not coming out. Why? Because maybe you have some, hypertrophy, prostatic hypertrophy. So that, to me, is a urological problem, and I don't cover it because it's not on the test. To say that someone's in the pre-renal stage of acute renal failure, what that means is that they have a decrease in urinary output. Less than 400 cc's in a 24-hour time. Why? Because there's not any blood, decrease in blood supply to your kidneys. There's a decreased blood supply to your kidneys. Now, why should there be a decreased blood supply to your kidneys? Well, maybe you're in congestive heart failure, or maybe you have a low blood pressure, either or. So to say that someone's in the pre-renal stage of acute renal failure, it means that they are not putting out the right amount of urine because there's not enough blood getting down to their kidney. When you say that someone's in the renal stage of acute renal failure, it means that they have 400 cc's or less of urine. And the reason why is because they have kidney damage. Their kidney is damaged. So if you have a choice to come into the emergency room, would you rather come in decorticating or decerebrating? And you would say decorticating. Because whenever you decorticate, right, you're like this, it means a cortex problem, whereas when you decerebrate, it means a brainstem problem. Good. So whenever you come in the emergency room, you'd rather come in decorticating. If you come in the emergency room, would you rather come in stuporous or obtunded? Obtunded. Far better be obtunded than stuporous. O comes before S. Anyway, if you're obtunded, you look like you're dead. But I shake you. Hey, wake up! You open your eyes. I'm like, what's your name? You're like, Mary. Boom, you go out. The stuporous person, I shake her. Hey, what's your name? She gobbles. Well, boom. Stuporous people gobble, obtunded people speak. You probably work with obtunded people. All right, if you came into the emergency room, would you rather come in pre-renal? You came in with renal failure. Would you rather be in the pre-renal stage or the renal stage? Pre-renal stage. So to say that someone's pre-renal means they have a decrease in urinary output due to a decreased blood supply down to the kidney. Why? Maybe the patient's in congestive heart failure, or maybe he has a low blood pressure. To say that someone's in the renal stage of acute renal failure means that there's a decrease in urinary output because of kidney damage. And the kidney damage could be to the parenchymal tissue, or it could be to the nephrons. We'll concentrate on the nephrons. If you have a problem with your nephrons, you have what's called acute tubular necrosis. And you hate when anyone develops ATN, right? Because out of 100 people developing ATN, acute tubular necrosis, 50 of them will drop dead and die. So now you're left with 50. The 50 that you're left with, 25 of them will need hemodialysis for the rest of their life, and only 25 out of that 100 will walk away unscathed. So that you really don't like when people develop ATN. Many times people in the hospital are in the pre-renal stage, and because of, poor staffing or lazy doctors, they go from pre-renal into renal. Not so much in a critical care environment, but when I float, so sometimes they float me to a med-surg unit. If you ever want to crack somebody, make them work on a med-surg unit. No, you'll crack. No, you crack. I have the same patient. When I work med-surg, I got the same patients I had in the unit. Same exact people. Same exact people, only I got more of them, and I don't have a lot of monitors to make sure they're alive and stuff. Really. Because I know many times we transfer people up to a med-surg unit, not because it got better, but we need the bed. They're down here long enough, we need the bed. So if you ever want to like be put over the edge, work on a med-surg unit, then I can't imagine anyone wanting to work there. I mean, they work like dogs. They go like, we all work like dogs, but they work like real dogs. I mean, they got 12 patients, 8 patients. They're running around nonstop. I'm thinking it's time to leave. Anytime you're working in a particular specialty that has no men in it, you know you're being overworked. Right? Come on, you know it's true. Hardly find no male nurse on a med-surg unit. Most male nurses are like, you know what, I'm out of here. I'm going critical care, I'm doing ER. I'm out of here, I don't need this. So, just a sign. Women tend to tolerate abuse much better than men. Not that you should be proud of it. But anyway, here we go. Really, they should have all the nurses on med-surg unit just walk off the job. Just slip on the floor, leave. And the ratios are awful. All right. Although in some states, they're not that bad, because in some states, like California, and I believe the law just passed in Massachusetts, right? Nurse-patient ratios. So I know in California it's a 5-to-1 or a 6-to-1 ratio. 4-to-1? 4-to-1 for med-surg? Oh, 4-to-1. Oh, I thought it was like 5-to-1. I know in critical care it's 2-to-1 unless the bedside staff nurse believes it should be 1-to-1. Hello? But, all right, here we go. So again, when I'm on a med-surg unit, and I got somebody with a BP 70 pound, I can't go hanging normal saline on a med-surg unit. See, if I'm in the unit and your blood pressure drops to 70 pound, I'm hanging normal saline. I'm hanging normal saline, I'm opening this, I'm doing this, I'm putting it over here, and then I call the doctor and say, oh, by the way, I did this. Dopamine, da-da-bam, ba-bam, ba-bam. You're on a med-surg unit, you can't do nothing. I got to call up doctors to see if I can give Ms. Jones a Tylenol, you know, or an Advil. I got to like call up the doctor. So on a med-surg unit, when I have a patient that drops his blood pressure 70 pounds, I got to call up the intern. I call the intern, I'm begging him, please, I'll be down. There's 20 minutes later, I'll be down. 40 minutes later, an hour. Meantime, this poor person went from pre-renal into renal. And it only takes about, up to what? Could take as little as 40 minutes to go from pre-renal into renal. So now, let's see here. What gives you ATN? To be in the renal stage of acute renal failure, it means you have kidney damage. If it's to the nephrons, it's called acute tubular necrosis. The causes of acute tubular necrosis would be ischemia, lack of blood supply getting down to your kidney, i.e. congestive heart failure, low blood pressure, or nephrotoxicity can do it. Nephrotoxicity. And nephrotoxicity that you get from, aminoglycosides and some of the cephalosporins, dye, heavy metals, not the rock group though, eating heavy metal, right? Not the John, shut up that music, you'll go into acute tubular necrosis. No, it's eating heavy metals. But then I say to myself, you know what? If you're stupid enough to eat heavy metal, you deserve renal failure, okay? It's like, weeding out, you know what I'm saying? Acute tubular necrosis. Let's talk about this. Acute tubular necrosis can be caused by ischemia or nephrotoxicity. Okay. If it's caused by ischemia, it's probably because of some kind of hemorrhage, burns, sepsis, heart failure, transfusion reactions. If it's nephrotoxicity, it's caused by heavy metals, medications such as cyclosporins and aminoglycosides, street drugs, rhabdomyolysis, which is a breakdown of muscle tissue, and radiocontrast. So these are the things that cause nephrotoxicity. Now, when you have acute tuber necrosis, you have 3 stages. There are 3 stages to acute tuber necrosis. The first stage is called the oliguric stage, and it lasts anywhere from 10 to 17 days. And in this time frame of 10 to 17 days, you're not putting out any urine, hardly any. And you get an increase in BUN, you get an increase in your creatinine, an increase in your potassium level. You get fluid overloaded. You're going into congestive heart failure. And we're probably doing peritoneal dialysis on you. So that in the oliguric stage, which lasts anywhere from 10 to 17 days, you have an increase in BUN, creatinine, and potassium because you're not putting out any of your urine. And you also go into fluid overload and congestive heart failure because, again, you're not putting out hardly any urine. If you make it through this stage, and we're doing peritoneal dialysis on you, right? If you make it through this, you will then go into what's called the polyuric stage. Now, the polyuric stage lasts anywhere from 2 weeks all the way up to 3 months. In the polyuric stage, you're putting out urine. You begin to make urine. You're not making good stuff, good quantity, bad quality. But some of us think when we see urine in your Foley bag, some people are jumping up and down, thinks they're doing better. They're like, oh, look, we put out a lot of urine. And they're all happy and everything. Yeah, you're putting out a lot of urine, but it's not good quality. You're leaking water out of your tubules. You still have an increase in BUN and creatinine. The only thing is you're able to leak out potassium out of your damaged nephrons, and you become fluid depleted. So it's almost complete opposite of what was happening here. In the oliguric stage, you're fluid overloaded, congestive heart failure. In the polyuric stage, and I got to worry about a high potassium. In the polyuric stage, I'm worried about fluid depletion and a low potassium level. Then, after you get out of this, should you get out of this, you then enter into the recovery stage, which lasts anywhere from 3 months to 1 year, and this is when we pray that the kidneys regenerate themselves, because not everybody's kidney will regenerate themselves. So the recovery stage is anywhere from 3 months to a year, and again, remember when I said we had those 100 people, 50 of them drugged it and died, you're left with 50, and then out of that 50, 25 of the people will go home unscathed, and then 25 will need hemodialysis. Well, the ones that need hemodialysis, the kidney never regenerated. So these are the stages of acute tuber necrosis. But again, you see, to develop ATN could last about a year. So you really don't like when people go into ATN. And that's why when people are pre-renal, when they're in the pre-renal stage of acute renal failure, you need a nurse to save your life, because they're going to be that nurse to to check out, make sure you're in the pre-renal, and then get somebody there to get more blood down to your kidneys, or get your heart beating better to get more blood down to your kidneys, so you don't go into the renal stage of acute renal failure and develop acute tuber necrosis. Now, when you have someone with acute renal failure, how do you know whether they're pre-renal or renal? So when you have someone who has renal failure, they have less than 400 cc's in a 24-hour time, that you get report, and then you go assess your patient, and you see your patient has you're looking, you think it's in the tubing, you put it over here, maybe over here, you're trying to get something out of there, right? And hardly no urine. And you keep on going back, right? Look, next hour, hardly anything. Next hour, hardly anything. So now you say to yourself, is my patient pre-renal, or is this patient in the renal stage of acute renal failure? Is he in the oliguric stage? So how do you know when someone has a decrease in urinary output, how do you know whether he's pre-renal or he's renal in the oliguric stage? If both of them have a decrease in urinary output, how do you know which he's in? Well, there's certain things you could do to differentiate pre-renal from renal. You can look at the urinary sodium level. By looking at the urinary sodium level, you can see whether the guy is pre-renal as opposed to renal. the normal urinary sodium is 40 to 100. That's the normal amount of sodium in your urine. If someone has a urinary sodium level, right, if someone has a urinary sodium level 20 or less, it means they're pre-renal. See, the normal amount of sodium in your urine is 40 to 100. If I have somebody who has a urinary sodium level less than 20, it tells me that there's not enough blood getting down to my kidney. And whenever I don't have enough volume getting down to my kidney is going to hold on to water. My kidney will hold on to water in the attempt to increase the intravascular volume so that more blood gets down to the kidney. So whenever there's a decreased blood supply to my kidney knows to hold on to water to increase my intravascular volume so that more fluid and more volume can get down to that kidney. Now, if you have a low blood pressure, it's a good thing that your kidney's holding on to fluid. But if you have congestive heart failure, it's a bad thing. That's why they always call congestive heart failure a vicious cycle. Because if I'm in heart failure, I don't have enough blood getting down to my kidney because my heart is not pumping adequately. And if my heart doesn't pump adequately and there's not enough blood getting down to my kidney, my stupid kidney is going to hold on to water, increase my intravascular volume, and make my congestive heart failure worse. That's why they call congestive heart failure a vicious cycle. So that if you have somebody who has a urinary sodium less than 20, it means that they're pre-renal. Because if I'm not getting enough volume down to my kidney will hold on to fluid, but it will also hold on to salt, which makes the congestive heart failure even worse. So whenever there's not enough blood getting down to my kidney will hold on to water and hold on to salt. And if my kidney's holding on to salt, then I hardly have any salt in my Foley bag. So anyone who is having a urinary sodium 20 or less, they're pre-renal. They're dehydrated. So by looking at the urinary sodium level, you get a good idea whether people are dehydrated or not. Because having a urinary sodium less than 20 means that your kidney is holding on to salt, holding on to water in the attempt to increase your intravascular volume. And by holding on to sodium, I only have a little bit in the Foley bag. So you can look at the urinary sodium. If it's 20 or below, I'm pre-renal. If it's 40 to 100, I'm in the renal stage of acute renal failure. Now you might say, well, you just told me 40 to 100 is a normal value. 40 to 100 is a normal value when you have the normal amount of urine in the Foley bag. If you don't have hardly any urine in the Foley bag, you should not be having a sodium level 40 to 100. Because if you don't have enough urine in the Foley bag, your kidneys are supposed to be holding on to salt to hold on to water. But here, the damaged nephrons are leaking out salt. And that's why you have a sodium level 40 to 100. Does that make sense? So that, how do you know whether someone's pre-renal or whether they're renal? Are they pre-renal or are they in the oliguric stage of acute renal failure? How do you know? You look at the sodium level. If you don't want to look at the sodium level, you can look at the BUN creatinine ratio. Look at their blood work. People who are pre-renal have a BUN creatinine ratio of 20 to 1. People who are renal have a BUN creatinine ratio of 10 to 1. So if I have a BUN of 50 and a creatinine of 5, I am renal. I have a BUN of 100 and a creatinine of 5, pre-renal. I have a BUN of 80 and a creatinine of 8, renal. So you look at the ratio. If you're pre-renal, you have a 20 to 1 ratio. If you're renal, you have a 10 to 1 ratio. So you could do that if you want. If you don't want to do that, then you could do a Lasix or fluid challenge. You can even give Lasix or fluid challenge, and this is what most physicians do, most interns do this. If you're a nurse working in the SICU, surgical ICU, and you call up an intern and say, listen, my patient had about 2 cc's of urine in the last 2 hours. He'll say, you know what? Give him a fluid challenge. If you're a nurse working in the MICU, and you call up an intern and say, listen, my patient had 2 cc's in the last hour, he'll say, give him Lasix. So when you work in a surgical unit, it's give him fluids. You work in a medical unit, it's give him Lasix. All right. So I give you fluids and or I give you Lasix, and you put out urine. Not a whole bunch, but you put out more than you made the hour before. That's a positive response. It means you're pre-renal. You're in the pre-renal stage of acute renal failure. If I give you a fluid challenge or I give you Lasix and you don't put out like hardly no urine, you put out like less than what you did the hour before, then it means you're in the renal stage of acute renal failure. And usually when this happens, you know, you give them 40 of Lasix or whatever, and they're like, you call them up and they're like, all right, give them, you know what, give them 80. You know, give them 120. You know what, put them on a Lasix strip. You know what, wash them in Lasix, all right? When really, the other day, the patient was pre-renal, and because everyone sat on him, he went into renal. So this is how it's usually done by the interns. It's give them fluid challenge or give them Lasix, and that's how you differentiate pre-renal from renal. So again, how do you differentiate pre-renal from renal? Renal stage, meaning the oliguric stage. You can look at the urinary sodium level, you can look at the B-creatinine ratio, or you can give Lasix and a fluid challenge. If you're looking at the urinary sodium, if you're pre-renal, it should be 20 or less. Anything 40 to 100 in the light of no urine in your Foley bag means you're in the renal stage of acute renal failure. If you want to do the B-creatinine ratio, 20 to 1 means you're pre-renal, 10 to 1 means you're renal. This is easy. Tell you, it makes you want to go back into work, doesn't it? No? Not yet, eh? All right. We'll get you there. Hey, why don't you sell AEDs? You know, the automatic external defibrillator? Come on, I got friends that made millions on it. How easy is that to sell? And you don't even have to sell if you don't want to. You don't have to go knocking on anyone's doors. Hire people to do it. It's the in thing, you know. They cost about $3,000. If you buy them in quantity, it'll cost you about $900. I'm bad with math. Let's say it costs you $1,000 to buy one. You sell them for $3,000. But let's say you don't like to sell. You hate to sell. Put an ad in the paper for used car salespeople. They'll sell anything. When you sell a car, you only make like $100, sometimes $200. You don't make a lot of money when you sell a car. You tell these guys, you sell these things, I'll give you $1,000 for every one you sell. You know they're going to sell them. And I'd hire 10 of them. Hire 10 used car salesmen. And you say to this one, listen, you're going to go to every doctor's office and try to sell them. Doctor's office would buy them. It's a tax deduction. They get a decrease on their insurance. There's no reason why they won't. So you hit every doctor's office. You hit every dentist's office. You hit every health club. You hit every softball, little league, stadium, where the kids play ball. You go there. You do every camp. You do every skill facility. You do every health club. Go around. You'll find 10 areas, and they'll go around. I bet you they sell at least one a day. Used car salesmen, you don't think so? They definitely sell one a day. Go to the mall. Put one in charge of every mall. It's endless. Retirement communities. They have the clubhouse, right? They always have functions there. You don't think that these retirement communities would want to buy one and put one there? Of course they would. So here you got all these 10 guys and you give them all a different area. I bet you they sell one a day. Easy. If they're selling one a day, how much you making in a day? They're making 1,000 apiece. You're making what? 10,000. And they do this 5 days in a week. So how much you making at the end of the week? 50,000. That ain't bad. Let's say you only want to work 1 month. Just work 1 month. You make yourself 200,000, then you retire for the year. Let's say you're greedy. You're greedy. You're doing it in New York? No, you hire 10 people in Boston. Hire 10 people in Ohio. Fort Lauderdale. I do a few places in Florida. None of those people want to die. I do Orlando, Fort Lauderdale, Miami. So let's say you got 5 places. Now, 5 key places. If you have 5 places with 10 guys, right, selling one a day, how much you making? I don't know. I'm bad at math. I think you're making a lot of money. Well, you're 5 times the 50, so you're making 250. You're making $1 million a month. That ain't bad. So then you retire. No? All right, never mind. Here we go. Okay, get your CCRN. Hi, would you rather get your CCRN or make $1 million a year? Well, I'd rather get my CCRN. Electrolyte. You need to know a few things about electrolytes. They always ask you about hyperkalemia on the exam. Hey, anybody going to do that? It's a good idea, you know. I have friends that did in Las Vegas and now retired because they got legislation passed in Las Vegas. Because initially when they went out there, no hotels wanted to buy it, so then they had to work with some congressman out there, and so then he passed some law that says every hotel in Las Vegas or in Nevada has to have an AED. So then my friends then sold it, and so that's all they do. Well, now they're retired now. Because there are a lot of hotels out there. And people always dropping dead after they lose money or something. Hyperkalemia. All right, whenever you have a high potassium level, you get a peak T wave, right? Whenever you have a high potassium level, you get a peak T wave. Then, like 6.5, 6.8, peak T wave. Then you get a prolonged PR interval, right? Once you hit like 7. Then when it gets higher than 7, you lose your P wave. Then you get a widened QRS. Then it gets biphasic. Once you hit about 8. And then you do this. You hate when that happens. Why? It's the sine wave. Why? Because you're signing off. That's why. Someone I used to work with, she has asthma very, very badly. Matter of fact, she has a whole pocketbook full of those Bristol jets, you know? No, not Bristol jets. Inhalers. Bristol jets. Christ. Like those inhalers, right? She has a whole pocketbook full of them. So that's how you know that she's not... Her patient is not doing well. You know by how many times she spritzes. Right? She's like this by the bedside. You know, you're like, hey, Gail, your patient's coming up from the ER. He's coding on the elevator. She's like, she should, really, she should really retire. But anyway, so she's in real bad shape. So during the winter, she started really wheezing up a storm. So what they did, they put her on steroids for her asthma. The steroids made her gain weight. They also made her like crazy. So she stopped taking the steroids. And what happened is she wound up going into adrenal insufficiency from abruptly stopping her steroids, and she wound up having hyperkalemia, which is what you get with adrenal insufficiency or adrenal crisis. You get hyponatremia and hyperkalemia. So she came into work one weekend, and she didn't look good. This is like a week after she stopped the steroids. I'm like, yeah, what's the matter? You don't look good. She's like, I think I'm dying. I am so weak. You know what? I'm coming down with Guillain-Barré. I think I've Epstein-Barr. I'm like, either one. I think they're highly contagious, all right? So why don't you work over there? We'll be over here, all right? Wave if you need us. So then the following week after that, now it's 2 weeks she's off her meds, she came into work and she looked really, really bad. She looked really bad. She looked so bad, I said, Gail, let me get a morgue pack and wrap you. I'll keep your face open. Then when you croak, I'll seal it up like this, all right? But before I wrap you, let me just draw a little blood. So I drew blood, sent it to the lab, came back 3 o'clock in the morning. Her sodium level was 123 low. Glucose level was 73 low. And her potassium was 8.4, which is very bad. If you have renal failure and you have 8.4 potassium level, this is a good day for you. But if you have normal kidneys and you're 8.4 potassium, you're going to die. So anyway, I threw her in the bed, hooked her up to the monitor, and lo and behold, she was doing this. She was doing the sine wave. And you still talk when you're doing that. You don't talk for a long time, but talk for a little while. Then I call up the intern, and he's telling me, can you get me a machine that works? Get me a machine that wants a machine that works. I'm like, it does work. She's doing the sine wave. You do it hyperkalemia. No, you can't be talking and be doing that. I'm like, yes, you can. Not for a long time. So he's like, I want a new machine, you get a new machine. I'm like, hey. So, I stepped on his foot. He had no shoes on. Stepped on his foot. I threw him out of the unit. I said, if I see you here, I'll have you killed for $50, all right? Then I called up the attending. I said, listen, I hate to wake you up at 4 o'clock in the morning, but I'm in a teaching hospital, and it just dawned on me, there ain't nobody here teaching anybody anything, so you better get in. So then he came in, And he gave Gail calcium chloride, which works within 1 to 3 minutes. And right before your eyes, you see Gail's EKG go from this to this to this to this to this. Another life saved for $15-20 an hour. But anyway, Gail had muscle weakness. That's why she thought she had Guillain-Barré or Epstein-Barr. And she had EKG changes. And then, of course, the supervisor comes around to let her know that she wasn't going to get paid for the shift. Right? Not, how are you? Nothing. She wasn't going to get paid, just to let her know she wasn't going to get paid for the shift because she didn't give you have to give a 3-hour notice on night shift. 2 hours evening, 1 hour day shift, okay? And this is what she said. I'm like, yeah, you two, get out of here. How do you treat hyperkalemia? Calcium chloride, right? Calcium chloride. And you only give calcium chloride if there's EKG involvement. And calcium chloride doesn't lower your potassium level any, doesn't touch it. But what it does is it allows electricity to go through your heart normally. It protects your heart. You give insulin and glucose. Insulin, because it pushes and hides the potassium in the cell. Don't matter how much is in there. It's the warehouse. And then you give glucose with the insulin so you don't become more hypoglycemic. I can also give sodium bicarb. That pushes potassium in the cell. And I give K-Exolate, which is a wonderful drug. Hello. All right, a little bit about calcium and phosphate. Calcium and phosphate exist in a reciprocal relationship. Whenever your phosphate level is low, your calcium level is high. Whenever your calcium level is low, your phosphate level is high. It exists in a reciprocal relationship. All right. People with kidney disease always have a low calcium level. And the reason being is your kidneys make vitamin D. And you need vitamin D in order to reabsorb calcium from your gut. People with kidney disease, they don't make any vitamin D. Since they don't make any vitamin D, they're unable to absorb calcium from their gut. So that's why people with kidney disease have very low calcium level. They're very hypokalemic. And because they're a low calcium level, what's their phosphate level? High. So now you give this renal patient Basogel. Right? You give Basogel or Amphagel. Why? Not to coat their stomach, but to bind with phosphate. Amphagel, Basogel binds with phosphate, brings your phosphate level down, so when I give you Oscal, I can raise your calcium level up. So that calcium and phosphate exist in reciprocal relationship. Whenever your calcium levels are low, your phosphate levels are high. People with kidney disease have a very low calcium level. Why? Because your kidney makes vitamin D, and you need vitamin D in order to absorb calcium from your gut. Whenever you have kidney disease, you don't make any vitamin D, you're unable to absorb calcium, and thus people with kidney disease have a very low calcium level. Whenever your calcium levels are low, your phosphate levels are high. Okay. On the exam, they ask you, what are the clinical manifestations of hyperphosphatemia? So I got this wrong. Because whoever, I don't even know what the normal value is. I don't look at people's phosphate levels. Calcium, I know. I really didn't pay too much attention to phosphate. And what the heck's a hyperphosphatemia? I didn't have no clue. Especially when I read what the answer is, I would have never picked it. It's Shavastek. See, now I always said to myself, a Shavastek is a calcium thing. But see, whenever your calcium levels are low, or your phosphate levels are high, you do the same thing. Twitch, CC, Shavastek, and Trousseau. So that the signs of hyperphosphatemia are the same signs of hypocalcemia. Right? Which is Twitch, CC, Shavastek, and Trousseau. Twitch, CC, Shavastek, and Trousseau. So on the exam, when they ask you what are the clinical manifestations of hyperphosphatemia, it'd be the same signs of a low calcium level, which would be Twitch, CC, Shavastek, and Trousseau. And then, of course, if you have a high calcium level or a low phosphate level, it's the same thing, severe muscle weakness. Right? Very severe muscle weakness. My brother-in-law has indigestion or, like stomach problems. So he's always sucking on Rolaids or Tums or Mylanta or Maalox or whatever's on sale at Costco. So apparently Amphagel was on sale at Costco, so he bought like a big box of it, and he was slugging it along. Anyway, as time went by, he became very weak. And he's about 6'2", and weighs about 250, 260 pounds, very muscular guy. But as 3 months past 2 months or whatever passed by, he started losing weight, a lot of weight. Went down to 160, and he was weak. He was really not looking well. Went all the way down to 140 pounds. He wasn't looking good at all. And so he went to the Mecca of healthcare in New York, and they did a muscle biopsy and told him that he has some very rare neurological muscular disease that only maybe 200 people in the whole world have. So they sent him home with my sister to die, and they told my sister to get rid of living room furniture, and they told her to get a hospital bed and get a ventilator, even though he's not on one now, but eventually will be on one, just so that the children get used to it and everything. So I'd go over her house, and there's a hospital. Like, you work all darn weekend, and then I go over her house, and I see a hospital bed, a ventilator. I'm like, blaze. And it's just really sad, because he went down to like 140 pounds, and he had a walker, and he was, he'd walk, his pants are falling off, and walk by like, I told my sister, Mommy, shoot him for you? How can you look at him like that? I mean, not that I would kill him, but I mean, it did cross my mind, please. So then anyway, one day he's walking by me, and his pants are falling off, and he's got the walker. I'm like, and I noticed a thing of Amphagel in his back pocket. I'm like, yeah, what are you doing with that? He's like, I got the stomach problem. I'm like, how much you drink of that? He said, I take a swig here and there. And my sister says, wow, he drinks like a bottle a day. I'm like, how long has he been doing this? She said, he bought a case of it at Costco. He's been doing it for the last few months now. So then I said to myself, it's Amphagel. Binds with phosphate. Probably has a low phosphate level. Maybe this is why he's in the mess he's in. So anyway, I called up his doctor, who happened to be in the office, and I said, I said to whoever I spoke to, get him on the phone. It's an emergency, I need him on the phone. All right, so they put him on the phone. And I said, you don't know me, but I'm Al's sister-in-law, right? I'm a registered nurse? Okay. So anyway, Albert has like a rare neuromuscular disorder. Let me ask you a question. He came to you like a month ago. What was his values? You did blood work on him, right? What was his values? So he told me, he said, I don't have time to talk to you right now. I have a waiting room full of people. I'm like, you'll tell me right now. So then we had this big fight, and I said, listen, you need to tell me, or I'm getting my Toyota, I'm going to drive through your waiting room, okay? All right. It's not a threat, it's a promise. Okay. So then he said, all right, I'll be right back. So then he got back on the phone, and he tells me, he says, I don't know how to tell you this, seeing as you're going to be driving your Toyota through my waiting room. He says 1.3, and the normal is 3 to 5.5. And a month ago, it was 1.3. So I pick Al up, throw in my Toyota, we go to the hospital, I draw blood, blah, blah, blah. Came back, now it's 0.3. So what happened is they kept him there, they gave him K-Fos, green leafy vegetables, blah, blah, blah. Anyway, he's back to like 6'2", 260 pounds. Okay, so did he have a rare neurological muscular disease? He overdosed on Amphagel. Okay? So now, in my family, if ever you announce that you're a nurse, everyone, if they're eating dinner or whatever, they stop eating, they drop to their knees, they're like, nurse. And it's cute when the kids are playing, let's say they're playing hospital or something, they're all like, no, I want to be the nurse. They're all fighting to be the, I want to, because, they have stethoscopes, medical stuff we have around the house. I want to be the nurse. I want to be the nurse. No, you be the doctor. No, I'm going to be the nurse. I'm like, yeah. All right, now, look, nurse, 15 years. There's a chainsaw. Look, and there's more. There's some down here. These are chainsaws. Oh, look, a chainsaw. Male anatomy. Listen. I used to be a charge nurse, all right? Let me tell you. And I used to have physicians coming into my office yelling and screaming about my nurses. All right? Always yelling and screaming, Yeah, well, your nurses, they call me up at 3 o'clock in the morning, blah, blah. I'm like, shh, zip it. Right? And they come in, you're a nurse. Sometimes I didn't even want to argue. What I'd do is I'd have a picture. It was drawn by Frank Netta. He's a very famous male illustrator. He's a very medical illustrator. He's very, very famous, good illustrator. And I have a big poster of the male anatomy in my office. And I have these doctors coming in yelling and screaming about my nurses. And I'd be putting myself right under the picture like this. And somehow it just break the whole train of thought. I know, some of you think it's sexual harassment. Hey, get over it. So you may want to do that if you have doctors that are irate. Either that or kiss them, that's it. That's it, that works. When they start yelling, have everybody run over and kiss them. Male and female. That'll straighten them out. A weight gain of 1 kilogram in 24 hours will indicate a fluid retention of, right, 1,000 cc's. Good. Signs of rapidly developing alkalosis would include all but which of the following? Well, whenever you go very alkalonic, your calcium level drops. So you're going to get seizures, tremors, nervous irritability. You're not going to get obtundation. Which of the following drugs actually removes potassium from the body in the hyperkalemic patient? What removes it? And you would say K-exolate, right? K-exolate is what removes it. Good. The electrolyte abnormality that produces a U wave and depressed ST segment and ventricular irritability is hypokalemia. You get a U wave. You also get ST depression. Which EKG finding would not be observed in the presence of hyperkalemia? Which one will you not see? Right. When people are hyperkalemic, you do not have ventricular irritability. You will get prolonged PR interval, absence of P waves, and widened QRS complexes. Right. The glomerular filtrate rate can be best measured by evaluating the patient's what? And creatinine clearance. Creatinine clearance tells you about the glomerular filtration rate. Approximately 68% of sodium and water is absorbed where? What absorbs your electrolytes? And you will say, the proximal tubule is what absorbs my electrolytes. The loop of Henle is for concentration and dilution of urine, and the distal and collecting and distal convoluted tubules is where ADH works just to absorb water. The major function of the loop of Henle is concentration or dilution of urine. Good. Who reabsorbs the electrolyte? Proximal tubule. Which of the following activities performed at the distal convoluting collecting tubule? Water reabsorption under ADH control. Good. Who reabsorbs glucose, amino acids, phosphate, uric acid, potassium? Proximal tubule. Who concentrates the urine? Loop of Henle. A patient has a urinary output of 1,000 cc's in 24 hours with a urine sodium of 25. So these findings indicate what? Now, he's got a urinary output, all right? And the normal amount of sodium in your urine is 40 to 100. Now, once you get down to 20, then you have some kidney problems. If someone has a urinary sodium of 25, it usually would mean that the patient is on a salt-free diet, right? Because it can't be that he's in the renal stage of acute renal failure. You can't say the polyuric stage, because if he's in the polyuric stage, he may have 1,000 cc's in 24-hour time, but his sodium would be higher. Ischemia injury to the kidneys will usually commence when the mean arterial blood pressure falls below 60, right? Mean arterial pressure, 60 for 40 minutes. Good. The two most common causes of acute renal failure, or ATN, two most common causes of ATN would be nephrotoxic substances and ischemia. If you were to say nephrotoxic drugs and heavy metals, these both come under nephrotoxic things. So it's nephrotoxic substances and ischemia. Patient with acute tubular necrosis is differentiated from a patient with decreased renal perfusion, because only in decreased renal perfusion, which is pre-renal, because only in pre-renal What do you think the answer is? Because only in pre-renal the urine volume is low and the kidneys fail to respond to Lasix? No. Because only in pre-renal the urine osmolality is greatly reduced, meaning it's very dilute? No, not in pre-renal. Because only in pre-renal the urinary sodium is 40 to 100? No. Because only in pre-renal, and here's the answer, the BUN to creatinine ratio is 20 to 1. The oliguric stage of acute renal failure would not include which of the following? If you're in the oliguric stage of acute renal failure, you're not putting out any urine. Right? So if you're not putting out any urine, you're definitely going to have a high potassium level. You're definitely going to go into congestive heart failure. You're definitely going to have a creatinine of 9. If you have a creatinine of 9, because you're in the renal stage of acute renal failure, your BUN has to be 90 because you're in a 10 to 1 ratio. So it would not be a BUN of 20. In ATM, caused by nephrotoxic drugs, Lasix will what? Increase toxicity, right. All right, good. Hey, hang in there now. 18 minutes. That's how long it takes to do the next one. Hang in there. You're looking like Night of the Living Dead. You know what? You've been sitting the whole day. Something you never did before. Your buttocks are probably saying, hey, what'd you do, join QA? Now you know what a real job in QA is all about. Hemo, 3%, 6, little itty bitty baby questions. You're not going to have any problem with hemo. Most of the questions, the 6 itty bitty questions, most of them are dealing with DIC. Easy as pie. Let's talk about DIC. What's the problem when you have DIC? Is it clotting or bleeding? Both isn't the answer choice. What's the primary problem with DIC? Clotting or bleeding? Clotting, right. If it was bleeding, it'd be called DIB, D-I-B, disseminated intravascular bleeding. But it's not. It's DIC, all right? So the problem with DIC is clotting. It's an overstimulation of your clotting cascade. Whenever you have DIC, you clot, you clot, you clot, you clot, you clot. You use up all your clotting factors, so now you begin to bleed. Then whenever you make a clot, usually that clot will lyse in 7 to 10 days. In a body that has DIC, that clot lyses right away. Whenever a clot lyses into fibrin split products or fibrin degradation products, those clot fibers are anticoagulant in themselves and make you bleed even more. So with DIC, it's an overstimulation of the clotting cascade. You clot, you clot, you clot, you clot, you clot. You use up all your clotting factors, so now you start to bleed. And then because you made all these clots lyse right away into fibrin split products, which are anticoagulant in themselves and make you bleed even more. When people have DIC, you need to know that the clotting cascade is affected. And you know that whenever you make a clot, you can make a clot via the intrinsic pathway, or you can make a clot via the extrinsic pathway, that there are 2 different ways to make a clot. When you make a clot via the intrinsic pathway, it's because of some kind of endothelial injury. And that endothelial injury can be caused by ARDS, septic shock, low blood pressure. Whenever you have endothelial injury, you will then make a clot via the intrinsic pathway. Now, you don't have to know all these clotting factors, but what you use is clotting factor 12, 11, 9, 8. Whereas when you make a clot via the extrinsic pathway, you will be using clotting factor 7. You know, what triggers DIC via the extrinsic pathway, or what triggers you making a clot via the extrinsic pathway, is any kind of tissue injury. When you have an injured tissue, it releases tissue thromboplastin. And that will make the cascade of clotting go on via the extrinsic pathway. You know, the placenta and your brain has the highest amounts of tissue thromboplastin. That's why people with neurological events and obstetrical events are most common to develop DIC. Matter of fact, DIC is very common in obstetrical emergencies, whether it be abruptio placenta, placenta previa. All right, so this is the clotting cascade. You can make a clot via the intrinsic pathway, or you can make a clot via the extrinsic pathway. They ask you on the test, what triggers a clot to be made via the intrinsic pathway? You would say endothelial injury. Or sometimes they say, what stimulates the extrinsic pathway to make a clot? And you would say tissue injury, and that it releases tissue thromboplastin. After you go through whatever pathway, you will then enter into the common pathway where you use a little 5, a little 10, a little calcium, and then prothrombin will be converted into thrombin. Fibrinogen will be converted into fibrin, which is a clot. And then once you have this clot, plasmin in your body will work on the clot to lyse it into fibrin split products, which are anticoagulant in themselves. In a normal body, that clot will hang out anywhere from 7 to 10 days. In a body that has DIC, you have a lot of plasmin, and it lyses the clots right away. So in laboratory findings, when you have DIC, you get a decreased fibrinogen level, because you're using your fibrinogen to make all these clots. You get an increase in PT, PTT. You get an increase in fibrin split products, or fibrin degradation products, and you get an increase in D-dimers. Notice that this arrow would be going down, and these arrows would be going up. All you need to know is one arrow. Some of the treatment modalities. Heparin, you have to give heparin. And everyone says, no, you can't give heparin. But you got to give heparin. Heparin stops the clotting cascade. If the problem with DIC is an overstimulation of the clotting cascade, I give you heparin. I stop the clotting cascade. And when I give you heparin, and I'll give, a bolus, 5,000, 6,000, 7,000 bolus, and a unit bolus, and then I'll put you on a heparin drip. And then what I'll see is your PTT is very, very prolonged. But when I start you on heparin, your PTT gets narrower, and it becomes like 2.5 times the normal, which is what it's supposed to be when you're on heparin. And then once I see that shift of your PTT getting to be within the 2.5 range, then I'm going to give you fresh frozen plasma. I'm going to give you chiroprecipitate. See, to just give people fresh frozen plasma is a wrong thing to do. Because, see, if I don't give you heparin, and I give you fresh frozen plasma, and I give you chiroprecipitate, I'm adding more stuff to the fire. If you have an overstimulation of the clotting cascade, and I'm giving you fresh frozen plasma, chiroprecipitate, I'm giving your body more stuff to clot with. So you make more clots, and the clots slice right away into fibrin split products, and for sure you'll bleed to death. So I must give you heparin. Fresh frozen plasma, chiroprecipitate that has clotting factors 8, 13, and fibrinogen. And then, of course, I got to get rid of the triggering event. Heparin works all over the place. It inhibits the conversion of prothrombin into thrombin. Heparin inactivates the circulating thrombin that you have. Heparin inhibits the conversion of fibrinogen into fibrin. So it works all over the place, and that's why I want to give you heparin. I want to give you heparin because it works all over the place. So what heparin does is it neutralizes, well, first it prevents the conversion of prothrombin into thrombin. It neutralizes any thrombin that you have. It prevents the conversion of fibrinogen into fibrin. It also works on this pathway over here. So it does prevent you from making any more clots. So heparin is what you give. Some people may have what's called heparin-induced thrombocytopenia, known as HITS. This is not in your handout. You may want to jot this down. heparin-induced thrombocytopenia, known as HITS. In patients who do not have antithrombin 3, heparin may have the opposite effect, thus causing the blood to clot. So you need what's called antithrombin 3 in order for your body to metabolize heparin, and that some people don't have it. So heparin does not work as an anticoagulant to them. You ever have people on the heparin drip? I remember lots of times, not lots, but significant amount of times where I have people on the heparin drip and their PTT does not budge. And I'm turning it up, I'm turning it up, I'm turning it up. Then I'm convinced that pharmacy is not putting heparin in the bag. I'm convinced that they're not putting heparin in the bag. You know, so I make it myself. Really, this patient may have what's called heparin-induced thrombocytopenia, that they don't have the enzyme needed to break down and utilize heparin. So what happens is in their body, it has the opposite effect, and it causes sometimes their blood to clot. And this is a new medication, Encova. A thrombin inhibitor, which does not require antithrombin 3, is given instead of heparin. So, argatrobon. And they give that instead of heparin because it does not require antithrombin 3. T cells are responsible for tissue immunity. T cells track through tissue. T cells is like the army. It's like the army. You got the Navy, you got the Army. So T cells are like the army. And they track through tissue, looking for germs. Really, they're looking for viruses. They're looking for newly implanted organs as well. So T cells track through tissues, looking for viruses and newly implanted organs. The T cells. That's why, you know, when you put people on cyclosporin as a T cell suppressor, stops you from attacking that newly implanted organ. So you got B cells, and you got T cells. B cells are responsible for humoral immunity. They also make the immunoglobulins. The B cells make immunoglobulins. It makes IgG, IgA, IgM, IgE. And it travels after bacteria. Where the T cells is responsible for tissue immunity. And it looks for viruses and newly implanted organs. So if you come back, let's say you drop dead and you come back to life as a lymphocyte. You can either come back as a B cell or a T cell. If you come back as a B cell, you're in the Navy. You go through body fluids looking for bacteria. If you come back to life as a T cell, you're in the Army. You track through tissue looking for viruses and newly implanted organs. How easy is this? Makes you want to go into work. B cells. Oh, let's check the recall. B cells are responsible for humoral immunity. Hey, what's responsible for cellular immunity? T cells. The most common immunoglobulin whose primary effect against bacterial disease is, and I didn't tell you, but it's IgG. IgG is the most common immunoglobulin. But who makes IgG? B cells make it. Which of the following statements regarding cellular or tissue immunity is true? In other words, the T cells. Which of these is true? It functions in concert with immunoglobulins. No, it has nothing to do with immunoglobulins. It's important in the development of autoimmune disease and graft rejection. Yes. So that's the answer. Very good. The immediate administration of which of the following is essential in the initial management of anaphylaxis. And we'll be doing more of anaphylactic shock tomorrow when we do cardiac. But, yes, epi, right? Epi. Okay. Which of the following blood products contains factors 8, fibrinogen, and 13, and is given in hemophilia A and in DIC? You would say chiroprecipitate has clotting factors 8, 13, and fibrinogen. Good. DIC is disseminated intravascular coagulopathy is widespread inappropriate clotting that then will trigger bleeding. Good. The pathophysiology of DIC includes And you would say, you narrowed it down to 2. You narrowed it down to B and D. But B is really the right answer. You see, for you to pick D as the answer, enhancement of intravascular clots, well, that part is correct. DIC, that part's correct. And that's what happens when you're tired. You read an answer choice has 2 parts to it. So you read enhancement of intravascular clots, and your brain goes, yeah, that's it, go with that. Meanwhile, the second part is wrong, right? Because it's not an overproduction of clotting factors. So B is the answer. It's enhanced production of intravascular thrombin, resulting in increased fibrin and platelet aggregation. That's the right answer. It's like a nursing diagnosis event here. It's like, how many words can we use to say one simple thing? Which of the following laboratory diagnostic finding is not likely to be seen in DIC? What would you not see? Would you have a prolonged PT-PTT? Yes. Would you have a platelet count that's decreased? Yes. Fibrin split products that are elevated? Yes. You would not have an increase in fibrinogen. Your fibrinogen level is low because you're using fibrinogen in order to make a clot. Which of the following laboratory diagnostic findings were most likely to be seen in DIC? And you would say, if you have DIC, you're definitely going to see a prolonged PT-PTT. Because what's your fibrinogen level in DIC? Decrease. The intrinsic system of blood clot initiation is, the intrinsic system is activated by endothelial injury. Who's activated by tissue thromboplastin? The extrinsic system. Good. Release of what substance into circulation, secondary to retained fetus, abruptio placenta, and stress can cause DIC. Tissue thromboplastin. Whenever tissue is injured, it may release tissue thromboplastin, which will then trigger the extrinsic pathway to make a clot. The beneficial effects of heparin in DIC are thought to be due to its neutralizing whatever thrombin you have circulating, although heparin works all over the place. Here we go, wanted. People who work long hours, frequent mandatory overtime, few holidays and weekends off, must be able to keep massive amounts of paperwork up to date while making split-second life or death decisions. They must be immune to verbal abuse and be able to neutralize any occasional physical assault. Must display patience, kindness, understanding, and caring, even when personal life is coming apart at the seams. Must show no aversion to blood, vomit, oozy infections, or human body waste. Salary in no way commensurates with knowledge and ability, and only those interested in dealing with a depressing situation on a daily basis need to apply. Should put that on a t-shirt. All right, we're finished for today. See you tomorrow, 8:30. If you have any questions, come up and ask me, because if you raise your hand now, people will kill you. All right? I'll see you tomorrow. Come up and ask me if you have any questions.